Welcome to the Acute Medical Teaching Series. We are your hosts, Shifona
And Harrison.
both senior house officers from Salisbury District Hospital. This is a 12-part teaching series running over 3 months. You can find links to the other sessions on our YouTube channel or via Blackboard for the local Southampton students. This is our 12th and final session, and we will be looking at Hospital Acquired Pneumonia today.
So what is a hospital-acquired pneumonia? A hospital-acquired pneumonia is defined as a pneumonia that develops 48 hours after hospital admission. We know from our previous session on community-acquired pneumonias that pneumonia is defined as evidence of consolidation on a chest x-ray accompanied with clinical evidence of infection, for example raised inflammatory markers, a productive cough, shortness of breath or fever. If any of you have spent time on the wards yet, you'll know how common hospital-acquired pneumonias are. So why do they occur?
The most common mechanism is microaspirations of oropharyngeal pathogens. We know that inpatients, especially the elderly population, become more prone to aspiration as they are unwell. Their upper airways become colonised from the healthcare environment with various microorganisms, and this can be exacerbated by factors such as poor hand hygiene. They then aspirate these microorganisms, developing a HAP. Other mechanisms include macroaspiration, for example, they vomit, spread from inserted devices such as catheters, and direct inhalation, for example, infected patients in the same bay.
We know that past the 5th day of admission, the organisms which cause a HAP are much more likely to be those associated with the hospital environment. So these include organisms such as MRSA, so that's methicillin-resistant Staphylococcus aureus, and Pseudomonas. As these organisms often have enhanced antibiotic resistance, this changes the way we manage these patients with different types of antibiotics.
So how will these patients present? They will often report fever, shortness of breath and cough with purulent sputum. They can also present with pleuritic chest pain, crackles on auscultation, and their observations can be deranged in the form of low oxygen saturations, high respiratory rate, low blood pressure, and tachycardia. So how would we go about investigating these patients? We would get routine bloods on these patients, including a full blood count, Us&Es, LFTs, and CRP. We'd expect to see evidence of infection in the form of a raised CRP and raised white cell counts.
We should also obtain samples for microbiological sampling. These include a sputum MCS and blood cultures. We could also consider viral swabs to look for viral causes of infection such as influenza and COVID. We could also consider getting urinary antigens for pneumococcus and Legionella, and this would further help us target our antibiotic choices. We could also consider getting a blood gas, and this would allow us to check the lactate if we're concerned about severe systemic infection, for example sepsis, and also to assess their acid-base balance. And also if we're concerned about their oxygenation levels, we could also do an arterial blood gas to check their PO2.
In terms of imaging, we'd start with a chest x-ray, which would show evidence of consolidation. We'd consider getting a CT chest if there was any diagnostic doubt, or if patients were not responding to treatment, or if there were elements on the chest x-ray that indicated we were treating a complicated pneumonia, for example, cavitation.
So how do we go about treating a hospital-acquired pneumonia? We'd always refer to our local microbiological guidelines. So in Salisbury, for patients with a severe hospital-acquired pneumonia and they'd had an inpatient stay of more than 5 days, we'd be using IV tazocin first line due to the risk of Pseudomonas. If they, however, had been in the hospital less than 5 days, we would normally be more conservative with IV coamoxiclav. We also need to be aware that the above antibiotics won't cover methicillin-resistant Staphylococcus aureus. So if the patient is positive, for example, they've had previous microbiological samples showing this, or they come back positive on a swab, we need to be covering this with either IV vancomycin or IV ticaplanin. We'd also undertake supportive treatment with oxygen therapy, fluids, physiotherapy, dietary support, and we'd make sure, especially for our elderly patients, we have a respect discussion about sensible ceilings of care.
So what is the mortality of hospital-acquired pneumonias? Unfortunately, HAPs have a mortality rate of 10%. We know that those infected with Pseudomonas are at increased risk of death.
Thank you for watching our teaching session today. We are your hosts, Harrison
And Shifona.
Don't forget to fill out the feedback teaching form below. See you next time.